In this video, I'd like to demonstrate to you the skill of synthesizing the information contained in the STEM and formulating your own list of problems, and potentially a management plan as well if you've got time. Here, I must give thanks to Dr. Susie Miles, who taught me this technique for the short answer questions, but I'm going to apply it here in the viva section. So there are a few key things I'd like you to take away from here. The first thing is that you've got 2 minutes to organise your thoughts. The more that you practice this skill, the better you'll become. Second point is that I want you to wake your examiner up by hitting them between the eyes with an opening statement that is so composed and so insightful that the examiner will form the impression that this trainee knows what they're talking about. Third point is that yes, I agree with answering the question where there is one, but if there is an opportunity for you to mix into your answer an overall perspective that shows your maturity and experience as a trainee, it will go a long way to achieving the goal of convincing your examiner to pass you. And the fourth point I want to make is this, that everything that they put in that STEM is there for a reason. That's why it's really important to get into the habit of trying to find the key words in the STEM, because it will influence the whole viva. Okay, so I'll do the first few untimed and then I'll put myself under the pump with 2 minutes for the others. So here we go. This is the first viva from the 2000 first sitting exam. So I'll talk as I go, just explaining what I'm thinking. So here it says that I'm called to assist. I've got the on-call registrar, and why don't we use the highlighter here? So I'm going to highlight that I'm called to assist the on-call registrar in intubating a patient. Why isn't that working? Neck hematoma. Can I highlight here? No, it won't let me highlight. Following a cervical fusion, same day. Okay, so this patient's bleeding. He's 66. He's got type 2 diabetes. Cervical myelopathy. Is that an anterior cervical fusion? Iliac bone graft. Grade 2 on early intubation, which is reassuring. So it looks like the reg has done a rapid sequence intubation or induction, and he's now unable to ventilate, or to intubate, sorry. Okay, so what are the issues here? So this is what I'm thinking. So the issues are you've got a registrar in trouble, or registrar who needs help. You've got a patient with a potentially difficult airway. Due to post-operative bleeding. This in turn might lead to hemodynamic instability. You've got a patient who has had an RSI. potentially able to wake them up. And that's about it. So my management. So if I'm not on site, and it doesn't specify in this stem. So the first thing is you're going to say to the examiner, this is an emergency situation. Okay, so you've basically got an unconscious patient unable to intubate. The second thing is, if not on site, ensure the registrar calls an arrest and tell them that you are going to be there ASAP, and you're already on your way to your car. Third thing is to establish whether the registrar is able to maintain an airway. If so, get them to wake the patient up while you're on your way in. Once you're there, or if you're already there, you've got a few options. So what, you're going to reposition the patient. Establish what the registrar could see, or why they couldn't intubate. Depending on the clinical situation, you might wake up the patient. You might attempt an LMA to buy time. You might, if he's not an extremist, you might have a look. Or you might go straight for front of neck access. Okay, so that's just me thinking out loud and typing as we go. So you can see here what I've done is, I've tried to highlight the important things. And then I've tried to synthesize it. Basically, this whole scenario is saying, how mature are you as an anaesthetist? What are you going to do? And I think the most important thing here is to recognize this is an emergency. This isn't something that you stuff around with. So your opening statement should be something like, this is an emergency situation where clearly there is a patient with a difficult airway due to post-operative bleeding and potential hemodynamic instability. There is a registrar who needs help, and I have been called to assist him. I'm unsure whether I am on-site or off-site, and this will influence my decision making. Given it's an emergency situation, and if I'm not on site, I would ensure that the registrar calls an arrest and tell them that I am going to be there as soon as possible while I'm on my way to the car. I will also try to establish whether the registrar is able to maintain an airway, and if so, I would ask them to wake the patient up while I'm on my way in. If I'm already there, we have a few options, and it will depend on the clinical scenario. I think the key to this case is whether I am able to ventilate the patient, and if so, I would consider repositioning the patient, establish what the registrar could see or what they couldn't, or establish exactly why they couldn't intubate. And then I would also consider, again, waking up the patient, perhaps reversing with Sugamidex to have the patient breathing spontaneously. I may consider attempting an insertion of a laryngeal mask airway. I would also consider performing laryngoscopy, or if the patient's in extremis, I may consider going straight for front of neck access. Okay, so let's move on to the next question. So the next question, I'm going to time myself. We'll do it in 2 minutes. I won't be highlighting the areas, but what I'll do is I'll type the salient points as I go. And once 2 minutes is up, I will then attempt to present from what I've written. So we'll go here, we'll start our timer, and we're away. So, oops, issues. So it's a young man. Post-MBA. ICU. Post-laparotomy. Post chest injury. Tachycardic. Great sepsis. Management. Okay, so that's my 2 minutes up. So, my opening statement for this patient would be, this is a young man who is post motor vehicle accident who presents with potential sepsis. He is post laparotomy and has a closed chest injury. So my differential diagnosis would include pneumonia or a bowel leak or an anastomotic leak, so abdominal sepsis. My approach to this patient would be to assess and diagnose the patient, ensuring that the patient has adequate oxygenation and remains hemodynamically stable. I would review his notes, looking particularly for the mechanism of the motor vehicle accident. I would be looking at the operation report to assess what happened previously in theatre, and whether there is potential for any bowel injury. I would also like to review the notes to ensure that there are no other complicating medical conditions. I would review his investigations, in particular looking at his full blood examination for a white cell count and his chest x-ray for any signs of collapse and consolidation. I would adopt a multidisciplinary approach, speaking with my intensive care colleagues and also with the surgeons about potentially managing this patient. I would also consult infectious diseases to potentially ascertain what the best antibiotic to treat this patient would be if an infection is considered. Okay, so moving on to the next one, we'll restart my timer. So starting now. Okay, so that's my 2 minutes up. Here you can see, so what am I trying to say? So my approach to this would be, my opening statement would be that this is a pediatric case of an open fracture of the skull with an embedded foreign object, and so it needs to be treated. The surgery is scheduled for 5 a.m. And theoretically the patient would be fasted by that time, but I would still like to treat the patient with a rapid sequence induction given the history of trauma. The patient is cooperative, and given that they've been transported by air, I presume that they have IV access, but if there is no IV access, then I would strongly consider obtaining intravenous access prior to performing a rapid sequence induction. She will also require intravenous access for antibiotic cover. I think the main issue regarding this case is the timing of the surgery, whether it should actually be brought forward, and also the issue of the safest way to induce this patient's anaesthetic. Okay, let's do the next one, and I think this will be the last one for this video. So I'm going to reset and start. Okay, so this is an elderly woman with abdominal sepsis whose operation probably needs to be done, but I would question whether she has an advanced care directive in place and what her functional status is at home. She has an unclear history, but on examination likely has aortic stenosis. She is also in pain and maybe hemodynamically compromised without the physiological reserve to respond to her condition. Her blood pressure is lowish and she may be beta block, which is preventing any heart rate response. In addition, there is no ICU bed, so this is very high risk surgery.